This next section is the complications of myocardial infarction. So remember what we said about being a specialist in internal medicine? What happens after all the initial therapies are done? Now, the other part about the complications of myocardial infarction, they all have in common hypotension. So a person is admitted to the CCU, which is either the coronary or cardiac care unit, with an inferior wall myocardial infarction. He's received thrombolytics, he's received beta blockers, he's received aspirin and nitrates, nitroglycerin, morphine and ACE inhibitor and a statin. He's received everything, and now he's suddenly confused. He's confused because he's hypotensive, he's got a pulse of 40, hypotensive, a pulse of 40. His lungs are clear to auscultation. Now, one of the other things stylistically about our course is that we are actually trying to avoid really long stems like this because we're not going to have this as a reading comprehension exercise. Next, the mix-up questions are in general longer than many of the questions on the real examination. Because remember, the mix-up questions are a home study course. So they're meant to be super long and super hard, so it sends you out to have to go read up and study up. So most of the time we're going to be just saying, hey, aspirin, yes or no, if you have a person who's had an ulcer and myocardial infarction. Answer, yes, aspirin, yes. Let's just get right to the point. And the point to this person is that there is hypotension, Canon A waves. Canon A waves in the neck, and a murmur, a systolic murmur, non-edematous. He's confused because everybody who'd be have this type of hypotension is confused. He is confused because he's hypotensive. Now, here's going to be a Conrad Fisherism. This presentation of complication of MI with hypotension. Complication of MI with hypotension alone could be a valve rupture, could be a septal rupture, could be wall rupture, left ventricular wall rupture, tamponade, septal rupture, hypotension, regurgitation, mitral regurgitation, aortic regurgitation, all complications of MI, all hypotensive. It could be that the MI has spread from the inferior wall to the other walls of the heart. Okay, so the first question is, you have a data set. What's the most likely diagnosis? The second question will be, what is the best initial and most accurate tests? The final question is, what's the most common therapy? What's the best initial therapy? In order for you to relax on test day, no one ever relaxed by saying somebody, hey, relax. That makes you more nervous. You relax by saying, you know what we're going to do? We're going to give you all of the answers, all of the questions. We don't know which one you're going to get. You could be getting the question, what's the most likely diagnosis? You could be getting what's the best initial test. You could be getting what's the best initial therapy. I just said in this section of complications of MI, complications of MI with hypotension can be wall rupture, valve rupture, septal rupture, tamponade, spread of the MI to the other valves, sinus bradycardia, VTAC. So how will you recognize them? And the answer is that's what these tables is for. So you're going to fill in and write this here. The first thing is, when you see what in the case? Well, when you see tachycardia and rales. Tachycardia and rales with a murmur can be the mitral regurgitation. Well, if there's mitral regurgitation, then the echocardiogram is definitely the test, and maybe a balloon pump and surgical repair is the therapy. What would you see to make sure that the answer is, here you're going to fill in, is septal rupture. How would you answer septal rupture? Tachycardia and rales. This patient does not have tachycardia and does not have rales. So valve rupture and septal rupture in this question are the two most common wrong answers. Because valve rupture and ventricular septal rupture result in tachycardia and rales. You'd see tachycardia and rales. If there's tachycardia and rales, well, how are you going to tell that this is septal rupture and not just the valve rupture? Because it will describe a step up in saturation, increase up in saturation as you go from your right atrium to your right ventricle. Because unless somebody put your lungs at the level of the tricuspid valve, why is the saturation 75% in the right atrium and the central venous pressure But now the saturation's 88, 90% in the right ventricle because there's a hole in my heart. Echocardiogram, balloon pump, surgery. You're going to fill this in your book that you printed out. Well, how do I know it's not wall rupture, tamponade? Because the chief complaint in wall rupture or tamponade would be, you know, I woke up feeling very dead today. I felt so dead this morning because I was dead. So tamponade or wall rupture will result in sudden death, pulseless electrical activity. That's how you know it's tamponade. And the best initial test is the echocardiogram, EKG and the echocardiogram. And then the treatment is either cremation or above ground burial or taxidermy or surgery. Try and fix it. Now, why are all of those impossible in this case? Because what you see here in the case for this one is you see bradycardia. So you're going to fill in your table. This is bradycardia. How do I know it's not sinus bradycardia? Huh? How come it's not sinus bradycardia? Because there's Cannon A waves in the neck. Cannon A waves in the neck. No Cannon A waves, it could be sinus bradycardia. Cannon A waves are the sign of atrial systole against a closed tricuspid valve. Atrial systole against a closed tricuspid valve. That's Cannon A waves. It's atrial systole against a closed or immobile tricuspid valve, so the blood bounces backwards up into the neck. That would be third degree AV block. Bradycardia, hypotension, Cannon A waves, bradycardia, hypotension, Cannon A waves, third degree or complete heart block. Bradycardia, hypotension, Cannon A waves, third degree AV block. And with third degree AV block, the best initial test, of course, is an EKG. Finally down to the treatment question. Ooh, let's see. Oh, let's go back to this one. Here's our case now. We have a complication of MI. We know that this cannot be valve rupture or wall rupture or extension of the MI or tamponade because there's bradycardia. We also know that it can't be valve rupture or septal rupture because the lungs are clear. Valve rupture and septal rupture and extension of the MI give you rows. And if they are for air for a long time, they get edema. What's up with the murmur? Well, the murmur, I don't know. There's always, a lot of people have murmurs, okay? He's got a systolic murmur, whatever. But no amount of valve rupture or septal rupture can give a murmur and give bradycardia and clear lungs. So the question becomes, when you know that this is third degree or complete heart block, what is the best initial therapy? The most common wrong answer for first is pacemaker. The right answer is atropine. Atropine. Bradycardia, hypotension, distended neck veins. Bradycardia, hypotension, distended neck veins. Atropine. Bradycardia, hypotension, distended neck veins, because atropine works faster. And atropine, he does need a pacemaker. It's third degree AV block. So the question is not saying, does he need a pacemaker sometime? The question is saying, what's the best initial therapy? Does he need a pacemaker sometime? Sure, he needs a pacemaker sometime. But what he needs first is he needs atropine. So the best initial therapy for third degree AV block, atropine. You might say, oh, but fishy, atropine doesn't always work. Well, you know, atropine is like the love, okay? The love. Just because it doesn't always work doesn't mean you shouldn't try that first. So you try the love, and even though it only works in 50%, you still try that first. Then you get a pacemaker. That's like a prenuptial agreement. A 68-year-old man is admitted for the inferior wall MI and develops sudden hypotension, tachycardia, distended neck veins. Now, distended neck veins does not mean the same thing as Cannon A waves. Cannon A waves is very specifically pulsatile in conjunction with the heartbeat, because Cannon A waves are like a cannon shot up in your neck. That's how Stokes and Adams were able to describe third degree AV block before the invention of the EKG. Stokes and Adams described third degree AV block in the 1840s in Dublin in a person they were called to see because they thought he was having a seizure. And if you didn't know what blood pressure was, because the sphygmomanometer was not invented at the time, you would say, oh, look, the guy passed out and he's shaking some. Looks like a seizure. He had bradycardia. They couldn't feel a pulse. That's how they know it's hypotension and the Canon A waves. And that's the description of third-degree AV block. So this is hypotension and distended neck veins and clear lungs. So their blood pressure is unchanged during inspiration. That's the biggie. Blood pressure is unchanged during inspiration. Oh, and everybody who's hypotension, a bolus of saline is good. Bolus of saline when you're hypotensive is like flowers as a gift. It's never wrong. So what's the next best step in this guy? Right ventricular leads, the echocardiogram, Swan-Ganz catheterization, pericardiocentesis. Bradycardia, hypotension, distended neck veins. No change in blood pressure with inspiration. It is right ventricular leads. How come this is not pericardial? How come this isn't pericardial tamponade? Because pericardial tamponade is the most common wrong answer for this question. It's not pericardial tamponade because the question described no change in blood pressure with inhalation. There is no pulsus paradoxus. So since there's no pulsus paradoxus, this is not tamponade. This is a right ventricular infarction because half the people who have an inferior wall MI, have a right ventricular myocardial infarction. So the management first is to flip the leads. You see that normally what happens is that the leads go across the left side of the chest. It goes across the left side of the chest. So what we do is you just flipped it. We just flipped it so that the leads go across the right side of the chest. Right ventricular infarction. And the management of the right ventricular infarction is simply to give fluids. There's nothing special or different about it except just giving a lot of fluids, increasing the filling pressure. A 72-year-old man is admitted to last week with an anterior wall MI. He got all the usual treatments of the aspirin and nitrates, beta blockers, statins. Trandolapril is just another ACE inhibitor. On his 5th hospital day, he's got new chest pain and a new murmur at the lower left sternal border. What's the lower left sternal border? What's the lower left sternal border? The lower left sternal border is also, can be either where the tricuspid valve is, aortic pulmonic tricuspid and mitral, aortic pulmonic tricuspid and mitral, aortic pulmonic tricuspid and mitral. So the lower left sternal border can be where the tricuspid valve is. And his right heart cath shows oxygen saturation in the right atrium of 75%. But now in the pulmonary artery, the saturation's higher. How come the saturation is higher in the pulmonary artery? And the answer is because he has developed, which problem? He has developed a hole in his heart. This is a ventricular septal rupture where he's got a hole in his heart between his ventricle and his right ventricle and his left ventricle. So the key issue is a step up in saturation. Now the mortality from an ST segment elevation MI, is the mortality from ST segment elevation MI is going up or down in the United States? The mortality from ST segment elevation MIs is going way down because the kind of MIs that would result in wall rupture and tamponade, left ventricular thrombus and aneurysm, septal rupture and valve rupture were much more common when we didn't have angioplasty to be able to immediately revascularize, didn't have statins, didn't have stents, didn't have 2 antiplatelet drugs. So what would happen is that the wall of the heart would simply die off and weaken and rupture. And the wall would rupture, the septal rupture, the valves would rupture, and that's how you died. The mortality from an anterior wall MI is down by over 70% in the last quarter century. It's harder to die of an anterior wall MI because we can revascularize you before you necrose. Oh my goodness, are you expected to really know how to auscultate hearts? Yes, you are. Which of them increases with inspiration? When you inhale, does venous return increase or decrease when you inhale? When you inhale, does venous return to the heart increase or decrease? It increases. Venous return increases the same way that when you inhale, the diaphragm drops and air comes into you. When you inhale, does venous return increase to the right side of the heart or to the left side of the heart? It increases to the right side of the heart. So all right-sided lesions get louder with inhalation. All right-sided lesions get louder with inhalation and with exhalation. All right with inhalation and all with exhalation. Because when you exhale, you squeeze blood out of the lungs and into the left side of the heart. Inhalation, right-sided lesions. Exhalation, left-sided lesions. A man is transferred. He managed to survive your care in the intensive care unit, the CCU, 5 days after an MI. No further chest pain. He's now ready for discharge. What are you going to do? Oh, what are we supposed to do? Well, we're supposed to stress people post-MI to see if they need a cath. You stress them post-myocardial infarction because you want to see, I'm sorry you had that myocardial infarction, but how's the rest of your heart doing? You had that myocardial infarction, but how's the rest of the heart? Is the rest of the heart alive or is it dead? Well, you do the stress test because if you have ischemia on the left, if you have ischemia on the rest of the heart, you want to see if there's still residual ischemia, because if there's residual, reversible or irreversible? Reversible or irreversible? Which one are you looking for? You're looking for residual, reversible ischemia so that you can fix it. Oh, we want to do CK. We want to be able to see if we can fix it. So echocardiogram is good, but it doesn't matter whether it's now or it's 6 weeks, because you're going to give the guy an ACE inhibitor anyway. Holter monitor, not necessary, because that's what he was in the intensive care unit for. He had telemetry monitoring in the intensive care unit. Doing a Holter after 5 days is worthless because the arrhythmia is going to occur, what time? They occur within the first 24 to 48 hours. 72 hours at the outside. But 5 days later, no point in doing a Holter. Besides, you're going to give him beta blockers anyway. Electrophysiology studies is the answer to the question, what's the most accurate test of arrhythmias? I'm looking for the site of Wolff-Parkinson-White. I have a person who's had syncope and I can't figure out why. That's what the electrophysiology study is for. When is the EP study the answer? I have syncope and I don't know why. And it sounds very cardiac, but I can't find it. I have possibilities of runs of ventricular tachycardia, and I want to see if they're inducible. If they're inducible, I tickle the heart and I induce it. Ooh, I need to do something. I need to put an implantable defibrillator. But I'm doing an exercise tolerance test to see whether angiography is necessary. Because after the infarction, the dead part might be dead and the rest of the heart is normal. So there's no point in cathing someone. Because in other words, if the person had an infarction, if the infarcted part is infarcted, well, there's no point in reperfusion to dead tissue because it's dead. And if the rest of the heart is normal, there's no point in reperfusing if it's normal because it's normal. So you're looking for residual, reversible ischemia so you can fix it. Bypass, which of these? 30% doesn't count. Left main counts, but not at 40%. Left main counts, but not as 40%. 3-vessel disease or left main, or 2 vessels in a diabetic. Because diabetics, Hippocrates said, dangerous diseases require dangerous cures. Is bypass surgery going up or down in the United States? The frequency of bypass surgery, up or down in the United States? Bypass surgery is going way down, because we have better medications. When the bypass studies were done in the 70s and 80s, 1970s and 80s, which means for many of you before you were born, when the bypass studies were done, we didn't have the routine use of stents. We didn't have the routine use of dual antiplatelet therapy, and we didn't have routine use of statins. And that's why we don't need the bypass as much. So which of these will benefit him most? Ooh, we like all of them. Relaxation methods. What are you going to do about a relaxation method? Who can even agree on relaxing? I get on camera to relax. Weight loss is good. We're all for weight loss. Pneumococcal, they all look good, don't they? but tobacco cessation is the fastest. If you stopped all tobacco smoking in the United States, the average lifespan would go up by 2 to 3 years if you stopped smoking. Now, the patient's wife says, "Doctor, doctor, 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 will my husband have sex with me?" And you say, yeah, sure. And she says, "Oh, that's funny because he wasn't having sex with me before." So now here's an example. There are only three circumstances in our whole course where occasionally I have to say something which I have a particular problem with. One, screening sigmoidoscopies. It's a legitimate screening test, but what type of person would take a test that only goes up 60 centimeters when 40% of the cancers are in the right colon? But sigmoidoscopy is a legitimate answer. HIV, giving antiretrovirals to everybody, even if their T cell count is 1,000. Okay, if you say so, it's the answer on the test. It's the answer on the test. It's the answer, it's the answer, it's the answer, it's the answer. This one, 10 years ago, the answer would have been no waiting, jump on it. Italian foreplay, yeah. All right, but now you have to say, no, you have to wait. You have to wait about 2 weeks for an inferior wall MI, 6 weeks for an anterior wall MI. Okay, so you have to wait for either that or the stress test. Either that or a negative stress test. Now you know why to do that negative stress test. So the thing is the sex post-MI, you have to wait longer depending on the size of the wall. 2 weeks for an inferior, 6 weeks, 4 to 6 weeks for an anterior wall MI. Veins being discharged. Here's the feel-good question. Now I know here I feel good about everything. Yes, nay, no, aspirin, beta blockers, ACE inhibitors, statins, Oh, what did the Dalai Lama say to the hot dog man? Make me one with everything. 2 antiplatelet drugs for every MI. Bare metal stent goes for a month with 2 antiplatelet drugs. Coated stents goes for 6 to 12 months, depending on the nature of the stent and who you're reading. But the thing is, coated stents go longer. Medicated stents go longer. Everybody on 2 antiplatelet drugs, a beta blocker, an ACE, and a statin. If the echocardiogram is normal at 6 weeks and there's no LV dysfunction, you do not need the ACE inhibitor permanently. Do you need the beta blockers permanently? Yes. Do you need the statin permanently? Yes. So what causes orthodeoxia? Orthodeoxia. Desaturating while sitting up. Desaturating while sitting up. And the answer is, well, you know, when you have when you have kidney disease on the basis of liver disease, kidney disease on the basis of liver disease, kidney disease on the basis of liver disease is called hepatorenal syndrome. The kidneys are normal, it's just that the liver disease is killing off your kidneys. Orthodeoxia is a feature of hepatopulmonary syndrome. And hepatopulmonary syndrome means the lungs are sick on the basis of liver disease. We think it's because of vasodilation in the lungs so that as you sit up, you desaturate. Hepatopulmonary syndrome. Which of these increase, oh my goodness, drug interaction questions, do I really have to know these? You don't really have to know them, you just have to know them if you want to pass your test. So drug interactions. Well, you see, the thing about drug interactions, cholestyramine lowers everything because cholestyramine only binds things in the gut. Amoxicillin doesn't have any significant interactions with these. Cholestyramine binds things in the gut and tends to decrease levels of digoxin, decrease levels of warfarin effectiveness, and that's why you have to increase warfarin and digoxin for people who are on cholestyramine. Now, you're a started patient on amiodarone. The patient's on digoxin and warfarin. Welcome to the world's greatest drug interaction question. So the point is, aren't you glad you're taking this examination now? If you were taking this examination 25 years ago, you would have had to be doing drug interaction questions morning, noon, and night. So amiodarone has an effect on these medications. Does it increase their metabolism or decrease their metabolism? Amiodarone decreases their metabolism. So since amiodarone decreases the metabolism of both digoxin and warfarin, you have to decrease the dose because amiodarone decreases the metabolism of both digoxin and warfarin. So if you don't decrease the dose, you'll end up with digitoxicity or bleeding. A man with angina is going to have a coronary angiography. He's got a history of a rash. So what do you do to prevent the allergic reaction? Don't get angiography. Get a CT calcium score. Will steroids decrease the risk of allergic reactions? Yes, they will. Epinephrine. Oh, that's wonderful to give epinephrine to people who have coronary disease, because you know why epinephrine will decrease the risk of rash? Epinephrine will decrease the risk of rash because when you give epinephrine to someone with coronary disease, they die. They have sudden death, and if you're dead, you can't have a rash. So no giving epinephrine to people who have possible coronary artery disease. So combining both glucocorticoids and antihistamines decrease the risk of rash. Now, what do you do to decrease the risk of renal toxicity with the angiogram in contrast? To decrease the risk of renal toxicity, you decrease the amount that you give and you hydrate. The only thing that's been proven to show that it really will decrease the risk of renal failure is hydration. We don't really have anything else. The N-acetylcysteine probably does not work. Can't hurt, not clearly helping. Giving bicarbonate, we want it to work, but it doesn't work. So the only way we really have to decrease the risk of renal failure with contrast is to give less contrast and to water those kidneys. The patients undergo a bypass graft. Ooh, sternotomy, cutting through my sternum, like a lobster, and is going to have bypass. So it's a very straightforward question about saying, what's the most common complication of a bypass? It has to do with being on the heart-lung machine. The most natural wrong answer is to say infection or stroke. Interestingly, it's neither infection nor stroke. This question, although it is one of the clearest questions there is, remember when I talked about contraindications and adverse effects? Contraindications and adverse effects are always on our test because they're clear. Contraindications and adverse effects, they're clear. What the hell is neurocognitive dysfunction? Neurocognitive dysfunction, pump head, means that what you have is a person who's just not thinking quickly enough. It's not from hypoxia, it's not from hypotension, it's from just being on the heart-lung bypass machine. It's not dementia, because people do remember what they are asking them, but they just come across kind of slow or just sudden. Neurocognitive dysfunction. All the people in Arkansas that watch me just turned me off, got mad at me. Complications of MI. Don't you feel a sense of accomplishment already? I do.